So it's lunchtime, time for another question for you to think about, ponder at your table. This one you've never seen before. This one is of monumental importance. Coaches of the world champion Golden State Warriors have made a concerted effort to provide a more nutritious diet for their players on their planes as they travel. So the question is, which food item did the players successfully rebel against and get kept on the plane? Now, we only have one decision per table. I think there's 32 tables here. Okay, we're going to give you 30 seconds to talk it over at your table. Okay, I think you've had a chance to introduce yourself, pick your team captain who's going to vote for your whole table. Okay, shh. So yes, more than 50% of the children, and I just want to give you some factoids, more than 50% of the children in California are of Latin American ancestry. So how many of you want to vote for nachos? Any tables voting for nachos back on the plane here? Not too many voting for nachos. Okay. Peanut butter and jelly sandwiches. Anyone voting for, well, we have one back there, a couple over there. Okay, one over there. Looks like about 6. What about Seth Curry's mother's chocolate chip cookies? Okay. The rumor was he couldn't shoot from more than 15 feet until he was eating those chocolate chip cookies. Haagen-Dazs Vanilla Swiss Almond. What about Haagen-Dazs, the major supporter of Bernie Sanders here, etc.? Any others? Okay. And what about Red Vines licorice? Anyone voting for red? We have a few. But it seems like the majority of you have voted for Steph Curry's mother's chocolate chip cookies. That's the type of answer that we make up at the Milken Institute. She doesn't have a recipe for chocolate chip cookies. And the correct answer is peanut butter and jelly sandwiches. Okay. So, as we discussed this morning, the value of health, public health, and medical research accountable for 50% of all economic growth. So I got a number of emails telling me, how does that happen? Well, let's take a quick look here. 11 year increase in average life expectancy over 4 million years of evolution. So as we think about what happened over 4 million years, we extended average life expectancy by 11 years. In the last 114 years, we've increased life expectancy by 40 years. 40 years and 100, little more than 100 years. And the groups that have joined here at the summit, this group of 14 giving you an opportunity to interact with people you maybe have never interacted with before. But by creating partnerships, it's amazing what you can accomplish. Let's take a look at some of those partnerships. 1938, President Roosevelt declared war on polio. The increased cases of polio in the United States peaked in around 1952. But when you compare the number of cases of polio, it just tells you a little bit about the world's most caring generation, those that, and the baby boomers who the parents took care of. There were precautions, not going to another person's house, and many other things that were driven, but no one was immune. There was a grim outlook, and if you visit the Center for Disease Control, it is compelling as you visit their museum to see these essentially indoor football fields and the projections of hotels, of iron lungs to keep people alive, and a video you can see of one of those patients who was kept alive for a decade in an iron lung. We're all aware that for many children's life-threatening diseases, we've made more progress than due to much more enrollment in clinical trials for children versus adults. Here's a copy of a card, a polio pioneer, one of 2 million children who enrolled by 1954 in clinical trials to test Salk vaccine. By April 12, 1955, it was ruled that the Salk vaccine was effective and potent, and polio was conquered. But the public health challenge, many people were concerned if they got the vaccine, they would actually get polio. So the country recruited the most popular individual in America at that time to see if he would get the polio vaccine to let America know it would be safe to take it. They recruited Elvis Presley. And if it was safe for Elvis, it was safe for everyone. And it was short history. Shortly thereafter, we saw the number of polio cases plummet here in the United States and eventually go to zero. Another public-private partnership between public health and medical research we see in the case of AIDS. A brave woman, Elizabeth Glaser, founded the Pediatric AIDS Foundation. Both of her children got AIDS and HIV because of her transfusion, which gave her, in a blood transfusion, HIV and AIDS. She formed an organization called the Pediatric AIDS Foundation, and the Milken Family Foundation, myself and many others. For those of you who are too young, that's little Richard in this picture here on the far left. Jimmy Connors, Peter, Paul, and Mary, etc. And the young man in the Madras shirt was her son, who's alive today. Unfortunately, Elizabeth did not live to see the benefits of what she achieved, nor did her daughter. And by 1987 in America, the challenge was from public health, aware loud and clear with the country's most popular talk show hosts going on television and warning the country. Let's take a look.
Hello, everybody. AIDS has both sexes running scared. Research studies now project that 1 in 5, listen to me, hard to believe, 1 in 5 heterosexuals could be dead from AIDS at the end of the next 3 years. That's by 1990. 1 in 5.
So you can imagine the concern of parents and anyone when the most popular talk show host has told you that 20% of the population might lose their lives in just the next 3 years. Well, the world was shocked again in the middle of this concern. On on November 7th, 1991, one of the most popular and recognizable individuals in the world went on television.
Because of the HIV virus that I have attained, I will have to retire from the Lakers today.
The day that I heard about Magic, it just sort of changed my love for basketball. It shook me up. You know, you get that feeling, probably the same type of feeling I had when my father died.
Caused me to, you can almost hear both of us with some tears in our eyes. And I'm choked up because he did call me. And when something happens, to you, and then you find out who really your friends are and people who really care about you.
So science advanced, programs of public health, and Magic was alive and well here at the Celebration of Science just a few years ago as we kicked off. And here's a picture of him with Tony Fauci from the NIH, who has led this effort. And you can see his smile and laughter is as big as it ever was, or even bigger today. Over 20 years, the risk of a pregnant woman passing AIDS to her children has dropped from 90% to 2%. And today, when you look at the number of people living normal lives with treatment around the world, you can see millions and millions of people, tens of millions of people who've had HIV and AIDS, living with it, not dying with it today. And more than 2/3 of every person living with AIDS is living in sub-Saharan Africa. And so when we talk about economic growth, if you knew that life expectancy in 2 generations in East Africa would increase by 75% as an investor, you'd be moving to that area. Just thinking about, in this short period of time, average life expectancy going from 43 to 75, how you would view the world. And it is no surprise that the world's fastest growing economies, due to advances in public health and medical research, lie primarily in Asia and sub-Saharan Africa today. And it is no surprise when we think about where the growth in the world's population is going to be in the balance of this century, that sub-Saharan Africa quite possibly will hold 100% of all the net increase in population growth, with a doubling of life expectancy. In Uganda today, median age is 15, as opposed to countries like China, which are now approaching the United States and will pass the United States in average median age in the next few years, as a country like China is growing as fast or faster in terms of its aging than any country in the history of the world. And so it's projected, when you look at China versus Nigeria or other countries, just this enormous change in population that's occurring in the world, and a great deal of it accountable for the advances in medical research and AIDS. So here's your second question. Most of you did poorly on the first, so here's another chance. In what year did the CDC publicly declare itself ready to combat possible biological warfare? 46, 52, 59, 64, or 1976? You have 10 seconds. Okay, time is up. How many of you are voting for 1946, the year of the baby boomers? The first baby boomers. Multiple presidents born in that year. Anyone voting for 46? A shame. Okay. 52. Anyone voting for 1952? 1. Okay, 1959. Anyone voting for 59? Very few. 1964. Okay. The hands start going up. And what about 1976? Okay, now, some of you are not going to be able to win this one because you didn't vote. Okay. Correct answer. So in honor of our guest, Tom Frieden from the CDC, here's your third and last question. Worldwide, what percentage of people with high blood pressure are adequately treated? Okay, time's up. Shh, we want to hear those hands going up. 14%, 1 in 7. A lot of hands. What about 21%? What about 33%? The good thing about this table here is they voted for every answer. Okay. They're covering their bets. Okay. 49%. Do you want to vote again? Anyone? Okay. And lastly, 67%. No hands. The answer? The majority of you got it correct. So we want to take you to West Africa, if we could, during the Ebola crisis. And you might not recognize that individual there in yellow, but if you could read the top of his hat, it says Tom. So we're honored to have Tom with us today. Thank you very much.
Well, as Mike said, we're delighted to have Tom Frieden here and honored to talk to us about the Zika virus. We're especially appreciative because Tom unexpectedly was on the Hill all morning and he has to rush back as soon as he's through here. So it's really kind of him to take the time to come here and join us in between. Michael Gerson is the person who's going to lead us in a discussion with Director Frieden. He's senior advisor at ONE, a bipartisan organization that battles extreme poverty and preventable diseases, particularly in Africa. He's a columnist for the Washington Post, a regular guest on PBS NewsHour and CBS's Face the Nation, as well as a book author. Until 2006, he was a top aide to President George W. Bush as assistant to the president for policy and strategic planning, involved in the President's emergency plan for AIDS relief, the President's malaria initiative, and the fight against global sex trafficking. So we're delighted to have him with us. And while Tom and Michael take the stage, here's a very brief video about the Zika virus.
The mysterious disease causing international anxiety.
The virus is suspected of causing birth defects in Brazil and is spreading across Latin America.
80% of the time, those infected with Zika don't feel sick.
But if you're pregnant, the effect of the virus may be devastating.
We're going to bring in right now the director of the CDC, that is Dr. Thomas Frieden.
Everything that we've seen so far doesn't suggest that there'll be a widespread outbreak of Zika in the U.S. But what's really concerning is this large number of birth defects that have been identified in Brazil if you're pregnant and you're thinking of traveling to a place that has Zika spreading, don't go.
Is it correct to say that we now have a case where Zika was transmitted sexually within America?
We had reports yesterday from Dallas with a test confirmed in our laboratory at CDC of someone who was not a traveler developing Zika, presumably and apparently from sexual transmission.
The CDC this morning is investigating 14 possible U.S. cases of Zika virus that may have been spread through sex.
The reality is we are just starting to learn about Zika virus, about its effects, and how to fight it.
It's a pleasure to be here with Tom Frieden, the man with the most terrifyingly interesting job in government. As director of the CDC, Tom has faced H1N1, right, initially, and Ebola, and now Zika. And these have almost been as difficult as dealing with Congress, where you've just been and you're about to go. And I will just say, in case after case, we've seen Tom doing a very difficult job very well, acknowledging fear, providing clear information, appealing for calm, and avoiding medicine dictated by politics. So it's a great record. The issue of the hour, of course, is the Zika virus, which is not a new threat, but an expanding and frightening one. Tom, will you start off by giving us a little background on what we know about Zika and the current situation?
Zika has been around since 1947. That's when it was first detected in Uganda in a primate. But it wasn't until the 1960s that it was known to cause human disease. It wasn't until 2007 that it was known to cause outbreaks, with a very large outbreak in Micronesia, on a very small island where 73% of the population became infected in just a few months. That population was only 9,000 people, and no serious outcomes were seen related to it. Rash, fever, joint pain, a little bit of conjunctivitis. What began changing was it began spreading through French Polynesia and then Brazil. And in Brazil, late last year, we began hearing about microcephaly. This is extraordinarily unusual. Rubella was identified as the cause of congenital rubella syndrome in 1941. In 1962, the cytomegalovirus, CMV, was identified as a cause of birth defects, including microcephaly. And in more than 50 years, no other pathogenic cause of a severe fetal malformation that I'm aware of has been identified. And as far as I know, never before has there been the possibility that you can get bitten by a mosquito and end up with an infant with a devastating birth defect.
Tell us what you're learning about how the virus is spread and what men and women can do to protect themselves.
Overwhelmingly, this is a mosquito-borne disease. Unfortunately, the mosquito that spreads it, Aedes aegypti, is referred to as the cockroach of mosquitoes. It lives indoors, it lives in dark places, it's hard to get rid of, it bites 4 or 5 people in one blood meal, so it can spread disease explosively. It's the same mosquito that spreads dengue and chikungunya and yellow fever. So anywhere in the world that's had a lot of dengue may have a lot of Zika in the future. It persists in the blood for about a week, so there's the theoretical possibility that it can be spread by a blood transfusion. That's why the FDA has issued guidance on Zika in blood transfusion, and companies are working on a test that will be able to screen blood for it. But what was unanticipated was the level of or rate of sexual transmission we're seeing. There had been one prior case that was likely sexual transmission in the entire world literature, and we're getting now about a call a day about what appears to be sexual transmission, and we're confirming many of those in people who have not traveled. And what we've seen is for men who have or have very recently been symptomatic, transmission to their female sexual partners, including several who've been pregnant. And the real point about Zika right now is we have to do everything possible to reduce the threat to pregnant women.
What parts of the U.S. are at greatest risk and why?
First off, the part of the U.S. that is Puerto Rico is at huge risk. There are 3.5 million people in Puerto Rico. There are 34,000 births a year. And when chikungunya hit Puerto Rico, it spread all over the island in just 2 months. And within 8 months, 1 out of 4 adults was infected. If that happens with Zika, we could see 700,000 infections by the end of the year, and thousands of infected pregnant women. In addition, parts of the southern U.S., including Florida, Texas, Arizona, have the particular mosquito vector. But you need not just the mosquito, you also need the human environment. Lack of screens, lack of air conditioning, crowding, all of those things greatly increase the risk of spread. So we may see some what we call local focal spread in parts of the U.S., but it would be unanticipated to see widespread transmission. That doesn't mean we can let down our guard. That's why it's so important that we strengthen our ability to track mosquitoes and the mosquito populations and control them. Places like Florida and Houston have very aggressive programs of reducing mosquito populations, but that's not consistent across all of the at-risk areas in the U.S.
Can you talk about what the CDC has learned about the link between Zika and microcephaly? Why is it hard to pin down causation in these cases? And do you have a good idea right now?
This is so extraordinary that the bar is very high to say it's definite. There's clearly an association. There's Zika, and then 6 months later, there's infants born with microcephaly. In our laboratories, we've identified, in the case of 2 cases of spontaneous miscarriage at about 8 and 11 weeks, we saw Zika in the placenta and a miscarried fetus. In 2 cases where there was an infant who had died within the first 24 hours from Zika, we identified the Zika virus actually in the brain and only in the brain. So it seems to be a neurotropic virus, a virus that targets, attacks, invades the brain and causes severe damage. But there's a lot we don't know. We don't know if there might be cofactors, other infections, toxins, nutritional factors that might increase or decrease the risk. We don't know what proportion of women who get infected during pregnancy will deliver a child with microcephaly. We don't know which phase of pregnancy is most risky, although first trimester would be most likely. And perhaps most importantly, we don't know of the infants born without microcephaly, do they have other health problems, some of which may only become apparent in years or even decades hence.
What is the CDC focused on currently when it comes to the technology that relates to this? What are the prospects for like a rapid test?
Well, we've made tremendous progress on testing. I'm very proud of our lab. Our lab has scaled up actually 3 kinds of tests already. We've produced about 500,000 tests of various types, 375,000 what are called PCR, or polymerase chain reaction. We can find out in a few hours if someone actively has the virus by testing their blood or other body fluids. But that's only when someone's acutely sick. In contrast, if someone was sick before, it's much harder to identify the infection. And we've produced 100,000, and FDA provided an emergency use authorization for this on Friday. We're rolling it out to health departments around the country and providing it to countries around the world of a test that can give a pretty good idea about whether someone was infected in the past. There is some cross-reactivity there. It may not be definitive for all people, but for many people we can give a definitive answer. We hope to get even better ways of diagnosing in the future. The lab is doing some very fancy things with virus-like particles and chimeric viruses that will allow us to do this a little faster and more accurately. And we should actually have that within a couple of months. It's striking to me. These are things that would have taken 5 or 10 years before, and we're taking now a couple of weeks or a couple of months. We're also thinking about how to improve mosquito control, because we have some pretty good tools now, but exactly the right mix of how to combine them, that's not so clear. And there are some new tools to control mosquitoes, ranging from genetically modified mosquitoes to a bacteria that can infect mosquitoes and make it less fit, to a very interesting insecticide that's completely non-toxic that our lab has been working on for many years that is now licensed to a couple of companies, which we think may have some promise.
How is the CDC working with other elements of the U.S. government on this challenge?
NIH has the lead on vaccine production, and we have some guarded optimism about a vaccine. Immunity against this type of virus tends to be lifelong and quite strong. And if we can do it naturally in terms of being immune, then it's easier to make a vaccine. So we do hope there might be a vaccine, and NIH is the lead on that. That will take, in a best case scenario, a couple of years, and it could take longer. It may not work out. So we can't count on it, but we have hope about it. We're also working with the Environmental Protection Agency about licensure of different mosquito control products, and they're very important in terms of regulation, and other parts of the Department of Health and Human Services for a comprehensive response to the emergency.
This is the next big global health challenge following Ebola. So what lessons that you learned on Ebola can you apply to this crisis, and how are they similar and different?
I would say that with Ebola, we had unknown unknowns, and with Zika, we have known unknowns. So with Ebola, we were surprised by certain things that we thought we knew. And when suddenly a disease that had caused a couple of thousand cases caused tens of thousand cases, we saw phenomena that we did not expect. With Zika, we know that there's an enormous amount we don't know. But with both of them, what's really key is that speed is of the essence. With Ebola, when we were able to turn the tide, it was because we began to be able to get into communities within hours or days of the beginning of the spread of the virus. Whereas with Zika, if we had known about it earlier, we'd be so much further along in terms of understanding the risks and being able to mitigate them. One of the things that's least well understood about Ebola is how close we were to a global catastrophe. In Lagos, in July of 2014, a man, a lawyer from Liberia, traveled there, got sick, and died. And a cluster of Ebola occurred. The initial response of the Nigerian public authorities was not very robust. Contacts weren't being traced. There was no place to treat people, including the doctors and nurses who died after caring for this Liberian lawyer. There was no organized response. And then the polio eradication infrastructure snapped into place to respond. We sent staff to the front lines. We had the deputy director of the polio response run the Ebola response. We brought in first 40, then 80 of the top Nigerian disease detectives who we had trained. They traced 800 contacts. They did 19,000 home visits. They found 43 people with possible Ebola. They built a treatment unit in 14 days. They isolated 19 people. When a patient went to Port Harcourt, a long way away, and started another cluster, they repeated the whole operation there, and they stopped the outbreak. If they hadn't done that, it is highly likely that Ebola would have spread not just through Lagos, which has the same population as the 3 countries of West Africa and 10 times as much travel, literally, but it would have spread all over Nigeria, all over Africa for months and years and undermined health and killed people because of both Ebola and the effects of Ebola. So time is of the essence. That's why it's so important that we build systems around the world to find threats when they first emerge, stop them wherever possible, and prevent them to the greatest extent science allows.
Because these diseases tend to attack the weakest part of the global immune system, right? One of the responses to that has been the Global Health Security Agenda. Maybe you can give us an update on that and how it relates.
The Global Health Security Agenda is fundamentally about keeping the world safer and America safer by being able to have a laboratory network that identifies problems when they emerge, disease detectives that can investigate them and figure out what's happening, prevention strategies so that whether it's vaccination or infection control or mosquito control, we can rapidly surge in and stop problems from becoming bigger problems whenever that's possible. And it's encouraging that we're seeing a tremendous amount of momentum for global health security around the world. I just got back on Friday from Ethiopia and Tanzania, where I was reviewing the global health security programs there, and they're already being used to respond to outbreaks, epidemics, to save lives, and to reduce the spread of disease. And sometimes when we do global health programs, countries say, we're not very interested in this, but if you want to do it, we'll do it. Here, we have an open field run. Countries are desperate for this. They want lab networks. They want to be able to figure out what's going on. They want trained epidemiologists, and they're willing to match us the money that we're putting in. Korea has put in $100 million. Other countries around the world are doing more. And I'm very encouraged by where we are with independent assessments. Right now, or pre-Ebola, we had a world of no accountability and not much assistance. There was no way of knowing what country was ready, and there was not much done to make countries more ready. Now we're building a system of real accountability where there'll be a scorecard, a grade, and a rating, red, yellow, green. How are you doing overall on preparedness and on prevention, detection, response? And that allows entities that want to support a government to say, okay, we'll support you, go from red to green here, but we're going to have a reassessment in 2 years to see if our money actually did that. So we have a system of accountability and an ability to do more assistance.
We've talked about the lessons from Ebola, but what are the lessons from Ebola and Zika for pandemic flu, the possibility of pandemic flu?
Pandemic flu is without a doubt the disease that worries us in public health epidemiologists the most. Because of what happened in 1918, 1919, because flu, even in a good year, kills thousands of people, we know we have to continue to build systems to understand flu around the world. We have to improve vaccination and treatment. We have to reduce risk wherever possible by reducing the human-animal interface that might allow mixing of flu viruses. Flu is the big one. Flu is the possibility of a pandemic that would be truly world-changing and could kill tens or even hundreds of millions of people. So the investments that have been begun on those are very important to continue to work on.
I have here the leading expert on TB in the world, so I wanted to ask about the latest on the National Action Plan for combating multi-drug-resistant tuberculosis and where those issues stand.
Tuberculosis is a disease that we can cure because of really decades of brilliant science, dedicated, rigorous controlled trials. We now know how to control virtually every patient, and yet still far too many patients aren't cured. What's driving multi-drug resistant tuberculosis around the world are poorly performing tuberculosis control programs. There isn't any country, any community, any hospital in the world that can treat multi-drug resistance faster than a bad program can create multi-drug resistance. So what we need to do is improve the treatment of all cases of TB and reduce the spread of TB in hospitals. TB can spread quite substantially in hospitals. Early in my career, I spent a lot of time in hospital wards reducing the spread of multi-drug resistant TB. But it's another example, like Ebola, like SARS, like MERS, like measles, of a disease that is amplified by healthcare settings. What the National Action Plan allows us to do is to strengthen core tuberculosis control programs and improve treatment of multi-drug resistance as long as we can continue to invest and increase our investments in doing that.
When you're talking to members of Congress who are politicians, they need arguments. What are the best arguments that you give them about the way that global health, which sounds rather vague, translates into health security for Americans and important national interests?
When I started this job as CDC director, I met with Senator Inouye, since passed away, and had a wonderful meeting. At the end of the meeting, I asked him that very question. And he said, "Don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money." And I've never heard better advice.
That makes a lot of sense. I think you were actually supposed to be here to talk about hypertension at a hypertension session. What would you have said at that session so that we can all hear it?
I'm sorry I can't be there this afternoon. I have to be at another meeting on Capitol Hill. But I think that hypertension may be proportionate to its health burden, the single most neglected problem in the world. It kills more people than anything else. It's the only thing that kills more people than tobacco. It's easily treatable. Prevention would save globally hundreds of billions of dollars just by small modifications in our diet. The medicines to treat it are very inexpensive. Monitoring is almost free. And yet, as Mike Milken showed, 13-14% of the world's population with hypertension has it under control. We have to do better. In this country, only 52% of the population has hypertension under control. And if you look at the Minneapolis-St. Paul area where they've really focused on this, it's about 70%. And if you look at Arkansas, where they were honest enough to actually look at how they were doing, it's about 30%. So we're at 50 plus or minus 20. But every percentage point increase in blood pressure control is going to translate into many fewer strokes and heart attacks, much less kidney failure, and much probably lower healthcare costs, but at least definitely healthcare costs that go to keeping people healthy rather than caring for them after a heart attack or stroke. So if there's one thing we want to improve in the healthcare delivery system, it's the management of hypertension. We should be able to get rates up to the 70 to 80% range. Nobody thinks it should be 100%, but it's pretty clear, and the SPRINT trial suggests that lower is better. And you can debate how to do that, but fundamentally it's about making sure the whole healthcare system is involved, having protocols, having an information system that gives you a rapid feedback loop, reducing barriers to patients, and focusing on what will make an impact. A few years ago, a colleague and I wrote an article challengingly titled, "Healthcare as if Health Mattered." This was about 10 years ago when I was not a federal official and can speak. And what we said there was fundamentally we don't organize our healthcare system to maximize health benefit. But if we did that, hypertension would be right at the top of our priorities.
You often come here to talk about emergencies in Washington. Address some of those other priorities that you have other than hypertension. I know that you have a list of kind of solvable problems when it comes to public health in America. What's on that list, and how do you rank those?
The approach I use is think of a spreadsheet. And the first column is the number of deaths or severe health outcomes. The second is what proportion of those are preventable. And the third is what proportion of those we're actually preventing. So I look at where can we make the most difference, and we identified a few winnable battles. Reducing tobacco use. Tobacco remains the leading preventable cause of death in this country. There are nearly 500,000 deaths from tobacco. We've made progress, but we can make more. Obesity and physical activity, we need to do better. We need to figure out what works and scale that up. Food safety, we've made progress, but we can make more, and we've worked well with industry. Motor vehicle crashes, we've made real progress. Teen pregnancy is at the lowest rate that it's ever been. These are areas where when we invest, we make a difference. But we've also seen now a horrific increase in prescription opiate use, and that's fueled an epidemic of heroin use. And there's a lot more we can do to reduce the burden of opiate addiction and death in this country. This is an iatrogenic epidemic. By the way, in medical school, they teach you how to say things without saying them. So iatrogenic is a polite way of saying doctor caused it. The idiopathic is another great term they teach you in medical school. It means, I know what your disease is, it's idiopathic, which means we have no idea what caused it. But for the iatrogenic epidemic of opioid abuse, we've increased fourfold our prescription of opiates, and exactly in parallel to that, the R squared is about 0.99, is an increase in deaths from opiates. So we need to do better protecting people from what are really dangerous medications. They have to be preserved for people who need palliation and in circumstances where they're appropriate, but they're vastly overused today.
And you're addressing the issue of overdoses as well, right? I mean, that's part of that.
It is, absolutely. It's one of the few things driving up mortality rates in this country. Most things are getting better, but this is one that's not.
Well, Tom, thank you so much for your willingness to answer some questions before you head back up to the Congress. I think mine were probably a little easier. But thank you for your clarity and your competence and your passion for public health. Much appreciated.
Thank you.
So if you felt you didn't get to ask questions of Tom, Tom will be joining tonight at dinner, a very prestigious group. maybe I think the first time ever. The head of the CDC will be with us. Robert Califf, the new head of the FDA, will be with us, and Francis Collins, the head of the NIH, will be with us at dinner, as will Minority Leader, former Speaker Nancy Pelosi, and Fred Upton will be back also tonight, in that his last answer this morning was so short he wants another chance to comment, plus some entertainment surprises this evening. So for the next couple minutes we have, we want to address this issue and with Lynn Goldman, Dean of the GW School of Public Health. And the question is, people ask, can you change your genes? Okay, am I destined to live with all the things that my parents, that I've been passed down from generation to generation, and your genes? Or if I can't change my genes, can somehow I change my reaction to what my genes are doing? And so, Lynn, why don't we talk about that for a couple of minutes?
Sure. So most of us, when we think about how we're unique, how I'm different from you and we're each different from one another, we think about the fact that we each actually possess a different genetic code. I mean, there's certainly a lot in common, but there's a lot of variability, obviously, among us. And yet, when we look at identical twins, and identical twins are twins that come from one single zygote, one single fertilized egg, have exactly the same genetic code. Yet, the coincident occurrence of disease among identical twins is not 100%. I mean, if all disease had to do with our genetics, and if it were all determined genetically, then it wouldn't be true that, for example, even something like hypertension is only shared among twins half of the time. And when you get to actual diseases, some of the most important diseases that we're dealing with, we're talking about either 25% of the time or less that if one twin has it, the identical twin also does. Diseases like breast cancer, like stroke, like diabetes. So we know that it can't be just genetic. And I guess the other thing we know is that some of those common diseases, as we sequence the genome and we're identifying all these associations, a lot of them aren't very strong, Mike. They're kind of, statistically not very strong associations. And there are many genes that seem to be involved, not just one. There's certainly diseases that are caused just by one gene, and they're very strongly genetic. But these more common diseases don't seem to be.
Well, it's been very interesting. Many of you, I'm sure, aware of the studies done on brothers or sisters where one stayed in Japan, for example, and the other one came to the United States. And within a generation, hormone-driven cancers in the United States from the one that came changed their lifestyle, changed their diet, changed the way they lived, increased almost to the level of the normal level in the United States, which could have been as much as a 10-fold increase. The children of the individual that had stayed in Japan remain with similar lifestyle, similar diet, still experience substantially lower levels, for example, in this case, of hormone-driven cancers. And so I think it underlines your point, Lynn, that there's a lot more than just your genes you're born with that results in these activities from that standpoint.
So actually, breast cancer is a good example of that phenomenon in terms of the Japanese migrants. But what the science is allowing us to begin to look at, which is actually truly amazing, and that is that we're now able to look at not just your genetic code, which genes you have, but also how that code is read, the expression of those genes. And we actually have the ability to look at very precise information about places on the genome that, if you may, control expression of various genes and are regulated through processes that are called epigenetics. And this is actually a fairly complicated area in terms of the science because there are a lot of different ways that cells do this, probably ways we haven't even discovered yet. We're very, very able to see one form of epigenetic change called methylation, where a little carbon atom is put on the DNA and can basically shut off the expression of a gene. But there are other things that happen too, alterations in these proteins that wrap around DNA, little microRNA pieces. But the bottom line is that when we look at, for example, identical twins, we see tremendous divergence in DNA methylation over time. A certain amount, even at birth, there are differences between identical twins in gene expression. By the time twins are 20 years old, 40 years old, 60 years old, they become more and more different. And very much supporting, probably this is true of your Japanese migrants, that if we, back when those studies were done, had a way to look at gene expression, we would have seen differences among those that stayed in Japan and those that came to the United States.
And we see, for example, a recent study that was launched in China here, where incidence of hormone-driven cancers have increased substantially in Shanghai, Beijing, where they have not changed, and particularly Western China. So we assume it obviously has something to do with lifestyle, air they're breathing, and other factors that are causing this to change.
The other thing we're learning, Mike, and I think that this is very important, is that to some extent, some of these changes are starting at the very beginning of life. And so that some of the research I've been involved with, we actually can see epigenetic changes in the cord blood of newborn babies who were exposed to mercury in utero, which is very compelling in terms of, we know that there are changes, neurologic damage that can be caused and other things that can be caused by that. Other studies have detected very small changes in children who eventually wound up developing cancer. And so some of these very early life exposures, whether it's if your mother smoked when she was pregnant, poor nutrition during pregnancy, exposure to environmental agents, right from the beginning is probably triggering some of this. And one of the best examples being the babies that were born during the Dutch famine after World War II. And we're in a very affluent country where there hadn't been malnutrition. And for a brief time at the end of the war, there was severe malnutrition. And those babies were born smaller, over time were followed up, had higher incidence of diabetes and cardiovascular disease. And you can actually see changes in their insulin receptor genes expression. It's just an amazing story.
Now, Lynn, I know an area that you've thought about and you've done work in is stress. So, we all think it's what is stress doing to us? Each of us have different level of stress. For some of the people in the audience, they don't want to be shooting free throws at the end of a basketball game, where they have to hit them both or the team loses. For others, they've lived for that opportunity. And so we have been very focused on an area between our Center for Financial Markets, and that is the stress for individuals or families where the value of the home went below the level of the mortgage. So they've lost their investment. One member of the family might have lost their job, and what that has done to the family, and have tried to look at visits to the emergency room, other issues. What in light of this issue of stress, one group with no stress, one group with a lot of stress, how has that changed?
It's incredibly important, and again, it's something that we're learning more and more about. My mother, who was a nurse, would have told me this is obvious, okay, but through science, we're able now to actually go in and measure the physiologic response to stress. We can look at hormone levels of cortisol, and we can see fairly clearly in many schools of public health, the scientists that have been involved in this research, that we can see differential levels of stress hormones in people in different neighborhoods, and certainly neighborhoods that have more foreclosures, poverty, that kind of instability, neighborhoods that have more crime, neighborhoods that have more, if you may, racial isolation, segregation has been found to be a risk factor for having more stress. And that, again, going back to mothers and babies, because I'm a pediatrician, that's my favorite topic, but women who are under stress during pregnancy are much more likely to have babies that are born preterm, babies that are, if you make growth, retarded, and we know that's a setup over an entire lifetime for chronic disease. And so I think although many of us have kind of known for years that if you may, these social determinants of health, we're calling it now, that these factors are important, we're now able to measure these determinants, to understand their impact, and if you may, to get a more refined sense of what that means. Tom Levis, who's one of the professors at GW, just joined us from Hopkins. He has done wonderful work trying to understand the kind of stress that many African American communities have. And I think one of the important discoveries that he made was that it's not the race, it's where people live, it's the place. He says place, not race, and particularly living in segregated neighborhoods with more stressors in the environment, that this is having a negative impact on health. And so this is very important in terms of understanding health disparities, but also I would say for understanding the health of people in our workplace, people that we're perhaps insuring or trying to cover, or people that are coming to see us even as individual patients that we often don't appreciate, that people are bringing into that interaction not only a different set of genetics, and we certainly want to be able to personalize around that, but I think we should be personalizing around some of these other factors too. The epigenetics are probably individuating ourselves even more than our genetics, I would argue.
So the point we want to just put forth is, once again, one that was stressed earlier by Atul, and that is that we are now able to test and look at a molecular level and other levels what occurs, not necessarily in the DNA that's been given to you, but in your interaction, your lifestyle, the environment you live in, and what the results are and why you might have a different reaction than someone else. So Lynn, thank you, and we're going to give them one more question here to take a look at before we break. Because I've noticed many of these tables, I should say most, did not get one answer correct.
My table had them all right, but I'm not with them anymore. So.
Okay, so you're the outlier there. So here's the question. The average serving size of soda today is 20 ounces, not including the free refill. Okay, so we're just giving you 20. What was the average size in 1955? 1955. Now it takes, how many years of human evolution would you say? 1,000, 100 to change? What do you think, Lynn?
More like 1,000, yeah.
Okay, so it might take 20 generations, but what have we done in 60 years here? So you're not going to be able to help your team here.
But I think they can do this one.
Okay, time is up. Time is up. So yes, there has been inflation. So if it took, let's say conservatively, 300 years of evolution to adjust, what is the change since 55, since Happy Days? Okay. So how many of you think it's A? It was 5.5 ounces was the average size. Anyone going for 5.5?
My table.
Just your table, okay. Well, there are
your table.
2, okay. How about 6.5? A number. How about 8 ounces? We've gone from 8 to 20. A popular answer? This table, Lynn, is so exciting. They've come together so well that everyone votes individually at that table. Okay, 9 ounces. 12 ounces. Anyone guessing 12? A couple back there. So he went 12 to 20, almost 100%. The correct answer is 6.5. So one of the areas we've been discussing is portion size. And it's very interesting when you talk about portion size, with a dramatic increase, for example, between France and the United States in obesity with women, soft drink portions, a portion in the United States is 52% larger than France, as what we say is a portion. Now, some other products in portion size, we could take a look at yogurt. So a carton of yogurt in the U.S., normal carton, is 82% larger than a carton in France. Now, candy bars, Philadelphia, they're 41% larger. Now, you've been thinking they're shrinking? Just go to France if you want a candy bar. And lastly, what about hot dogs? Hot dogs are 63% larger in the United States than France. And finally, that hamburger, if you looked at that hamburger of the 1950s versus today's hamburger. So when we talk about portions, we need to figure out where in the world are we when we're talking about portions. Thank you very much. Look forward to seeing you later.